So we start with the basics to the advanced, from anatomy, pathophysiology, medical management, surgical management, and then finally limb salvage and rehabilitations. So why the anatomy is important? Because this foot is a very complex structure. It have 26 bones, 33 joints, and more than 100 tendons and muscles and ligaments in the foot. So that's why it is very important to know all these structures before proceeding to the surgery or management of diabetic foot ulcers. So major bones are the calcaneum, cuboid, navicular, and cuneiforms. These are the tarsal bones, and then the metatarsal. So metatarsal 1 to 5, it have a shaft, head, shaft, and the proximal part, and distally it is connected with the phalanx. Then phalanx is from 1 to 5, all metatarsals have phalanx. So each phalanx have proximal, base. Each phalanx have the proximal part, base part, and the shaft. And the hallux have only 2 phalanx. In the hallux have only 2, rest have the 3 phalanx. Now come to the division of the foot. The foot is divided into the forefoot, midfoot, and hindfoot. So the hindfoot have talus and calcaneum. You see this calcaneum and talus. This entire is the hand foot and their joints. And then midfoot have these 3 bones, 5 bones, this composed of the navicular. This one is the navicular, then cuboid and cuneiform. 3 cuneiform bones are there. Then forefoot have all metatarsals. So the midfoot have 6 joints, including the talocalcaneo-navicular. If you see this calcaneum bone, then talus and navicular. So calcaneo-talo-navicular. This one is the one joint. Then calcaneo-cuboid. This is the cuboid, calcaneo-cuboid. And then cuboido-navicular. Cuboido-navicular. This is navicular, cuboid, cuboido-navicular. And then intercunicular. These are the 3 cunicular bones. So intercunicular. And then cunicular, cuboid, and cunicular, navicular. So these are the 6 joint in this midfoot. So you have to be very careful, and we see how they are connected with the different ligaments. We see the different ligaments. Talocalcaneo-navicular. So this is the talus bone, then calcaneum and navicular. So talocalcaneo-navicular, and you see this diagram in which it is clearly depicted that talocalcaneo-navicular. This is the long ligament, and then talonavicular, from talus to the navicular, and then there is a bifurcate ligament. In the bifurcate, there is 2 parts, calcaneo-navicular and calcaneo-cuboid, this bifurcate. So these are the ligaments which support the midfoot. So in the subsequent lectures, we will see when the sarcofoots, these ligaments are breaked and collapse of the foot. So especially the midfoot is the collapse. So the entire biomechanics of the foot is changed. And once the biomechanic of the foot is changed, the shifting of the pressure from different arches, which we are going to discuss, shifting of the pressure to one particular point, leading to the pressure necrosis and ulcers. So the other ligaments are the plantar ligaments, long plantar ligament, and plantar calcaneo-cuboid ligament. Then come to the arches of the foot. So after the ligament, arches is very important to shifting the entire weight of the foot from one part to the another part of the foot. So if you compare the sharing of the weight over the foot, so 60% over the heel and 40% over the front. But once you walk, it will shifted from heel to front. So there are two arches, horizontal and vertical. So in longitudinal arch, there are two longitudinal and one transverse. So if you see the longitudinal arch, there is two. One is the medial longitudinal arch and the lateral longitudinal arch. So in medially, it is started from the calcaneum to talus and the uniform bones, and then uh, that is the tarsal bones. So calcaneum, cuneiform, and tarsals. And then the lateral side, it is the from the calcaneum to the cuboid, and then the fifth, fourth, and fifth tarsals. And then the transverse arch at the midfoot in the head of the all metatarsals. So this is the medial longitudinal arch, where you see this calcaneum, talus, and navicular, and then cuneiforms. So from calcaneum, talus, and then navicular and metatarsals. Then support of these arches by the different ligaments. So first is the plantar calcaneo-navicular ligament. Plantar calcaneo-navicular ligament which supports. So why this is important? As I told that it's the entire weight is put on these ligaments, and this shift the weight from front to back or back to front while walking or running. Then another is the long plantar ligament, which is connected with the calcaneum to the head of the metatarsals. In between, it is connected with the cuneiform and cuboid bones. Then deltoid ligaments. It is supposed to be the strongest ligament. So once you walk, if you walk in uneven surface, there is lots of pressure over this. And especially the diabetic patients, they have the pliability is less and chances of rupture of these ligaments is very high. Then plantar fascia. It is also supports the string-like supports to these arches, and once there is a sudden stretch of these plantar fascia, there is inflammation, and that is called plantar fasciitis. Now come to the muscular support of these arches. So muscular supported, there is intrinsic muscles and extrinsic muscles. So intrinsic muscles, that is inside the foot, and extrinsic muscles, that is from the limb, and they come into the foot to support these arches. So intrinsic are the abductor hallucis and flexor hallucis brevis. So from the medial side, if you see the medial ligament, the medial side, the abductor hallucis and the flexor hallucis. And extrinsic muscles for the medial arch is the tibialis posterior, flexus hallucis longus, and flexor digitorum longus. So the tibialis anterior tendon, you see that it comes from anterior side going down and have a branches to support the all phalanges. So it attach with the all metatarsals. So all is the tendon of tibialis anterior. And then support of the longitudinal arch from the medial side. So the extrinsic muscles are the tibialis posterior and flexor hallucis longus and flexor digitorum longus. So all these three tendons are going down, and it attach to the tarsals and causing the string-like supports to the arch from the medial side. Then lateral longitudinal arch, it is formed by the calcaneum, cuboid, and metatarsals. So all these forms the lateral longitudinal arch. And it is supported by the intrinsic and extrinsic muscles. The intrinsic muscles are abductor digiti minimi and flexor digitorum brevis. And the extensor muscles are the peroneal muscles. So these peroneal muscles have the tendons going from lateral side and attached to the head of the fifth metatarsals. Then transverse arch. So the transverse arch is also important to share the force from medial to lateral. And once it is damaged, then flat foot is there. So flat foot, if you lose the transverse arch, the foot become flat and the pressure of different pressure area is increased and chances of ulcer is increased. Now come to the muscles of the foot. So it have a different layers. So 4 layers. One is the superficial layers, then middle layer, deep layer, and then interosseous layers. And there is a muscle layer on the dorsal surface. So in the plantar, the lowermost layer is the plantar fascia or this plantar aponeurosis, which act as a support for string-like support to the longitudinal arch. Then foot muscles, the superficial layers, it have a 3 muscles, abductor hallucis, abductor digiti minimi, and flexor digitorum. So these muscles is in the first layer of the superficial layer of the foot. Then middle layer. The middle layer is formed by the quadratus plantae and lumbricals. So this quadratus plantae supports to from the calcaneum to the other midfoot bones and the lumbricals to support the metatarsals. Then deep layer. So deep layer is also very important. It have a flexor hallucis brevis, abductor hallucis, which have a 2 heads. Abductor hallucis have a transverse head and oblique head. So this one is the transverse head and this one is the oblique head. So 2 head is there and then flexor digiti minimi. So this is the deep layer. So all these muscles layer is supporting to foot and during the walking and during the pressure itself. Then interosseous layers, there is plantar interosseous and dorsal interosseous. They are help into the abduction and adduction of the toes. Then dorsal surface have a muscles that is extensor digitorum brevis on this side and then extensor hallucis brevis. So extensor hallucis is there and extensor digitorum brevis is this side. So these are the muscles from the dorsum side. Then come to the concept of the plantar space. So why this is important? After these muscles layers, there is some space in the foot, which is important because all the vessels which travels or supply to the foot in these spaces. So they run through these sides and there are 3 main plantar space. One is the medial plantar space. You see the medial plantar space, it is present around the abductor hallucis and flexor hallucis brevis. And the central plantar space, it is present around flexor digitorum brevis, flexor digitorum longus, and quadratus plantae. And then the lateral plantar space. So these 3 plantar space are important. Why this is important? If there is any pressure or trauma or any pus pocket in these spaces, so it become compartment syndrome. And these compartments have high pressure leading to the compression of the vessels and further supply of the organs is reduced. Like for this example, if there is a mid plantar space, have a pus pocket or any trauma which causing increased pressure on this area leading to the compression of the vessels and result is necrosis on the toes. So that's why these spaces are important. And once there is any infection of these spaces, you have to release. Otherwise, there is a compartment syndrome. And Dr. Kari will tell you how to explore the foot. So to explore and open these spaces, that's why knowledge of these foot space is very important. So you see if there is a pressure leading to necrosis. And these are the practical examples. So during the surgery, you have to explore the entire space. Until unless if you not explore this space, you are not going to heal these ulcers. So the majority of the pressures or ulcers are in the first metatarsal joints, because lots of once there is a flattening of foot or during the walking, the pressure over this first metatarsal joints have high, and it leading to pressure ulcer on this. And there are lots of deformity in diabetic foot patients. There is lots of deformities which causing uneven pressure over these areas. So Hawaii chappals have, because see, flexor deformity is there. So once there is a neuropathy, the flexor muscles have dominant over the dorsal muscles. So the dorsal muscles are weak and flexors have a contracture. So it leads the deformity and change in the pressure area. If you see, pressure usually at the head of metatarsal, but in this patient, the pressure area change to the tip of these toes and leading to the ulcer of tip of these toes. So that's why you have to avoid these type of slippers. Then biomechanics of amputation. So once the patient is get amputated, the pressure area has changed. In normal patients, once he walk, the pressure area is at the toe area, and once there is a amputations, the pressure increase at the small area because there is no toe. So this large surface area have a increase per square inch pressure area, leading to the necrosis and ulcer. So you have to understand the biomechanics to prevent the ulcers. So how this infection is spread? Like this, there is a ulcer in the head of the metatarsals, and how it is spread. So once there is a ulcer, if the patient is continue walking and not taking proper treatment, this ulcer infection travel to the upper side of the limb and leading to the infections to entire area of this site. So you have to explore the entire site. Otherwise, if you're treating this area only, it will not going to heal because the infection is travel up to here. Similarly, in the lateral side, if there is ulcer at the fifth metatarsals, and if you are not aware of that this infection may travel up, you will treat only this area and that will not going to heal. So it will travel up. Similarly, in the dorsal side, it travels. So you have to explore all these sides. In the plantar surface, the all travel towards the midfoot. So you have to explore the entire midfoot. So the take-home message is that knowledge of foot anatomy is important to understand, and the biomechanics of the foot is also important to understand. And you have to understand how to spread these infections in the foot, and the knowledge of anatomy is helpful to prevent these ulcers and also guide to extend the surgery in infected foot. Thank you very much for patience hearing.